Bismillahirrahmanirrahim. This is RCOG guideline about the management of the beta thalassemia in pregnancy. Okay, first of all, I would like to tell you that whenever you study guideline from my video, it would be better if you have hard copy of that guideline, open it in front of you and listen to this video. Okay, because whenever you listen to the specific person about this specific topic, then you will have a very good understanding of that topic. Okay, so that is why I make the video. Otherwise you can open this guideline yourself, but whenever I open it in front of you and I explain a few important points of this guideline with you, then that give you a very good idea about the whole guideline. Okay, and you understand it very well. Okay, so let us start this guideline. Okay, I will start it with you. Okay, so what is written in this guideline about the beta thalassemia? It is nice accredited guideline. Okay, management of the beta thalassemia in pregnancy. Okay, in the purpose and scope, what is written. Okay, the purpose of this guideline is to produce evidence-based guidance on the management of the woman with the beta thalassemia and intermedia in the pregnancy. Okay, now what are the types of beta thalassemia? That is written here. Okay, exam question might be asked that what are the different types of thalassemia. Okay, we may have thalassemia major, thalassemia intermedia, and thalassemia carrier patients. So those are written here in this guideline. The thalassemia major women are those who require more than 7 transfusion episodes per year, and thalassemia intermedia women are those needing 7 or fewer transfusion per year, or those who are not transfused. And women who are thalassemia carriers do not require transfusion. It will include preconceptual, antenatal, intrapartum, and postnatal management and conception in both primary and secondary care setting. Okay, and it will not cover screening, as the British Committee for Standard in Hematology has published guideline for screening and diagnosis of thalassemia. Okay, so basically this is not for the treatment. Okay, so what is written in the introduction? In the introduction, first of all, in the first part of the introduction, we have hemoglobinopathies. Hemoglobinopathies have been written in the first part of this introduction. Hemoglobinopathies are one of the most common inherited disorders, and more than 7 lakh babies are born with a thalassemia worldwide each year, and there are 100 million women who are asymptomatic thalassemia carrier. The basic defect in thalassemia syndrome is reduced globulin synthesis and the resulting red cell having inadequate hemoglobin content. Okay, so basically globin chain is defective. Okay, and that is the basic pathophysiology. In exam, the questions related to pathophysiology can be asked as well. The pathophysiology of beta thalassemia syndrome is characterized by the extravascular hemolysis due to release into the peripheral circulation of the damaged red cells and erythroid precursors because of the high degree of ineffective erythropoiesis. Thalassemia major, which is homozygous beta thalassemia, results from inheritance of the defective beta globulin gene from each patient, and this results in the severe transfusion dependent anemia. The heterozygous states beta thalassemia trait, thalassemia minor, can cause mild to moderate microcytic anemia with no significant detrimental effect on the overall health. Okay, now what happens in thalassemia intermedia? In thalassemia intermedia is defined as a group of patient with a beta thalassemia whose disease severity varies, and at the severe end of the clinical spectrum of thalassemia intermedia, patients are usually diagnosed between the age 2 and 6 years, and although they survive without the regular blood transfusion, growth and developments are impaired. At the other end of the spectrum, there are patients who are completely asymptomatic until childhood when they present with a mild anemia and splenomegaly, often found by the chance during hematological examinations or family studies. The diagnosis is dependent on the patient maintaining a satisfactory hemoglobin level at the time of the diagnosis without the need for the regular blood transfusion, and patients with a severe form of the thalassemia intermedia, and those patients with a thalassemia major who has a poor access to the blood, who were previously offered splenectomy to help to reduce transfusion requirements. Splenectomy is no longer the mainstay of the treatment for the condition, but a considerable number of the both thalassemia major and intermediate patients have undergone splenectomy. Now, the cornerstone for the modern treatment in the beta thalassemia are the blood transfusion and iron chelation therapy. So that is the cornerstone of the treatment. Multiple transfusion causes the iron overload, resulting in hepatic, cardiac, and endocrine dysfunctions. The anterior pituitary is very sensitive to iron overload, and the evidence of the dysfunction is common. Puberty is often delayed and incomplete, resulting in the low bone mass. And most of these women are subfertile due to hypogonadotrophic hypogonadism and therefore requires ovulation induction therapy with gonadotropin to achieve a pregnancy. Now, cardiac failure is the primary cause of the death in over 50% of the cases. Improved transfusion technique and effective chelation protocols have improved the quality of the life and survival of individuals with the thalassemia. The mortality from the cardiac iron load has reduced significantly since the development of the MRI methods for monitoring cardiac and hepatic iron overload, liver T2 and Ferri scan, liver iron assessment, Ferri scan. Okay, and these methods are now available in most of the large centers looking after patients with hemoglobinopathy. And there are approximately 1,000 individuals affected by thalassemia major and intermediate syndrome in the UK. The absolute number of the affected individuals is unclear and currently being assessed nationally as a part of the National Hemoglobinopathy Register. Previously, the community affected was principally from the Cyprus and Mediterranean. However, currently the Asian communities, India, Pakistan, Bangladesh, account for 79% of the thalassemia birth, with only 7% occurring in Cypriot population who have taken advantage of availability of the prenatal diagnosis. High incidence area include the Greater London, Birmingham and Manchester. The NHS sickle cell and thalassemia screening protocol in England during 2009 to 10 identified approximately 16,000 women as a carrier of hemoglobinopathy, and partner testing was offered. 59% of the screen positive women had positive partner testing, and 1,006 couples were identified as being at higher risk of having a child with a clinically significant hemoglobinopathy, sickle cell disease or thalassemia. 396 couples accepted the offer of the prenatal diagnosis, which revealed 23 pregnancies offered by thalassemia and 46 fetuses that were carrier of thalassemia. The majority of the pregnancies affected by thalassemia majors were terminated. Now, identification and assessment of the evidence. What is written in here? The guideline was developed according to the standard methodology, so that is what it is written, so we don't need to discuss it. Now, preconception care. What are the additional risks to the woman and the baby? Thalassemia is associated with increased risk to both mother and the baby. In particular, there are issues surrounding the cardiomyopathy in the mother due to iron overload and increased risk of the fetal growth restriction. Okay, so mother and a baby, what are the risks to them? Basically, the iron overload causes certain problem in the mother and the baby. Okay, it can cause the cardiomyopathy in the mother and fetal growth restriction in the baby. In addition, with around 9 months of the lethal or no chelation, women with thalassemia major may develop new endocrinopathies, in particular diabetes mellitus, hypothyroidism, and hypoparathyroidism due to increasing iron burden. Now, what is the optimum preconception care for the woman with the thalassemia? At each visit with the thalassemia team, there should be a discussion and documentation of the intentions regarding pregnancy, and this should include the screen for the end organ damage and optimization of the complications prior to embarking on the pregnancy. Each specialist hematology center should have a guideline for the management of the pregnant woman with thalassemia. Women should be advised to use the contraception despite the reduced fertility associated with the thalassemia. Now, fertility may be reduced in the transfusion-dependent individual where chelation has been suboptimal and the iron overload has occurred, resulting in the damage to the anterior pituitary, and this may require ovulation induction using the injectable gonadotropin to conceive. And there is no contraindication to the use of the hormonal method of the contraception, such as combined oral contraceptive pills, progesterone only pills, the Nexplanon implant. Okay, and women with a thalassemia are best cared for in multidisciplinary team setting, including an obstetrician with expertise in the managing high-risk pregnancies and hematologists. And this team should provide pre-pregnancy counseling so that the woman is fully informed about how thalassemia affects the pregnancy and vice versa. The preconception evaluation involves a review of the transfusion requirement, compliance with the chelation therapy, and assessment of the body iron burden. And the assessment should include the optimization of the management and screening for the end-organ damage. At both local and the specialist center, the woman's aspirations regarding the pregnancy and contraception should be explored in consultation and discussion with hemoglobinopathy team, so that the decision making is shared, and this should be done well in advance of the proposed pregnancy, because of the prolonged period of the iron chelation therapy may be required to control iron overload prior to both induction of ovulation and pregnancy. Now, are there interventions which are beneficial at the preconceptual stage? Aggressive chelation in the preconceptual stage can reduce and optimize the body iron burden and reduce the end organ damage. There is evidence from the clinical trial that optimizing body iron reduces the end organ damage and can reverse the cardiac iron loading. Longitudinal studies show that the patient who have been optimally chelated are less likely to suffer from endocrinopathy or cardiac problem. Due to lack of the safety data, all the chelation therapy should be regarded as potentially teratogenic in the first trimester. Now, Dyspheroxamine is the only chelation agent with the body of the evidence for the use in the second and third trimester. The optimization of the iron burden is therefore critical, as the ongoing iron accumulation from transfusion in the absence of the chelation may expose the pregnant woman to the high risk of the new complications related to the iron overload, particularly diabetes and cardiomyopathy. Now, coming to the pancreas. The pancreas is the common in the woman with the thalassemia, and women with the diabetes should be referred to a diabetologist. Good glycemic control is essential pre-pregnancy. Women with established diabetes should ideally have a serum fructosamine concentration less than 300 nanomole per liter for at least 3 months prior to conception. This is equivalent to HbA1c of 43 millimole per mole. Diabetes is common in adult with thalassemia. Diabetes is multifactorial due to insulin resistance and iron-induced islet cell insufficiency, genetic factor, and autoimmunity. And similar to the woman with the diabetes without thalassemia, and HbA1c of less than 43 millimole per mole is associated with a reduced risk of the congenital abnormalities. HbA1c is not reliable markers of the glycemic control, as this is diluted by the transfused blood and results in underestimation, so serum fructosamine is preferred for monitoring. Now, coming to the thyroid. Thyroid function should be determined. The woman should be euthyroid pre-pregnancy. Hypothyroidism is frequently found in the patients with thalassemia. Untreated hypothyroidism can result in maternal morbidity as well as perinatal morbidity and mortality. And patients should be assessed for thyroid function as a part of the preconception planning. And if known to be hypothyroid, treatment is initiated to ensure that they are clinically euthyroid. Now, coming to the heart. All the women should be assessed by the cardiologist with expertise in thalassemia and or iron overload prior to embarking on pregnancy. Now, an echocardiogram, electrocardiogram and echocardiogram should be performed, as well as T2 cardiac MRI. Now, it is important to determine how well the cardiac status of the woman will support a pregnancy, as well as the severity of any iron-related cardiomyopathy. Cardiac arrhythmia are more likely in the older women who have previously and had severe myocardial iron overload and now clear of the cardiac iron. Okay, so that is what written here. Now, what is written in the next paragraph? The aim of the what is the aim for no cardiac iron? The aim for the no cardiac iron is that okay, and basically in this paragraph what is written, how to check which patient can get pregnant. Okay, the aim for no cardiac iron, the aim is for no cardiac iron, but this can take years to achieve, so care should be individualized to the woman. Otherwise, the aim for the cardiac T2 of more than 20 millisecond, and whenever possible, as this reflects the minimum iron in the heart. However, pregnancies with the successful maternal and the fetal outcomes have occurred with a low cardiac T2 values, T2 values of less than 10 ms is associated with increased risk of the cardiac failure. Reduced ejection fraction is a relative contraindication to pregnancy, and the management should be subject to the multidisciplinary discussion involving a cardiologist with expertise of the cardiac pathology in a pregnancy, and a maternal medicine specialist, and a hematology and obstetric anesthetist. Okay, now second point is that of the liver. Okay, and women should be assessed for the liver iron concentration using the Ferri scan or the liver T2. Ideally, the liver iron should be less than 7 milligram per gram dry iron. Okay, the liver and gallbladder and spleen, if present, ultrasound should be used to detect the cholelithiasis and evidence of the liver cirrhosis due to iron overload or transfusion related viral hepatitis. Okay, the second thing is that what is the importance of the target iron of less than 7 milligram per gram. A target liver iron of less than 7 milligram per gram is recommended because of the iron chelation is discontinued during pregnancy, and therefore transfusion, iron burden, and the risk of the iron overdose overload related complications increase. Anecdotally, ovulation induction is more likely to be successful when the iron burden is well controlled. Now, what to do when the liver iron exceeds the target range? If the liver iron exceeds the target range, a period of the intensive preconception chelation is required to optimize the liver iron burden. Now, at what gestational age can Dyspheroxamine be given? If the liver iron exceeds 15 milligram per gram prior to conception, the risk of myocardial iron overloading increase. So, the iron chelation with the low dose Dyspheroxamine should be commenced between the 20 to 28 weeks under the guidance from Hemoglobinopathy team. Now, what liver complications may result in case of the iron overload? Cholelithiasis is common in a woman with a thalassemia due to underlying hemolytic anemia, and they may develop cholecystitis in pregnancy. Liver cirrhosis and active hepatitis C may run a more complex clinical course during pregnancy. Women who are HCV-RNA positive should be reviewed by their hepatologist preconceptually, and women who have any evidence of the cirrhosis either due to previous hepatitis or as a consequence of the severe hepatic iron overload should be reviewed by hepatologists. Now, coming to the bone density scan, all the women should be offered bone density scan to document previous osteoporosis. Vitamin D concentration should be optimized with the supplements if necessary. Osteoporosis is a common finding in adults with a thalassemia. The pathology is complex but thought to be due to a variety of the factors including underlying thalassemic bone disease, chelation of the iron by chelation drug, hypogonadism, and vitamin D deficiency. And the most of the women with thalassemia syndrome are vitamin D deficient and often osteoporotic as well. All the women should have vitamin D levels optimized before pregnancy and thereafter maintained in the normal range. Now, red cell antibodies, ABO and full blood group genotype and antibody titers should be measured. Alloimmunities occurs in about 16.5% of the individual with thalassemia. The red cell antibodies may indicate the risk of hemolytic disease of the fetus and newborn. If the antibodies are present, they may be a challenge in obtaining the suitable blood for transfusion. Now, what medication should be reviewed preconceptually? Iron chelation should be reviewed, and Dyspheroxamine and Dyspheroxamine ideally discontinued 3 months before. Okay, Dyspheroxamine and Dyspheroxamine, these iron chelation should not be used. Okay, so we should remember these points. Okay, so in the next paragraph, what is written? It's written that which iron chelates are unsafe and which are safe. So that is discussed here. And women with thalassemia are often on the range of the drugs, some of which may be teratogenic. For example, Dyspheroxamine and animal studies with Dyspheroxamine did not show any teratogenic. Okay, so we were discussing that the animal studies with Dyspheroxamine did not show teratogenicity. However, there is only a limited safety data on its use in pregnancy. Dyspheroxamine and Dyspheroxamine should ideally be discontinued 3 months before conception and women converted to Dyspheroxamine iron chelation. Okay, now what is Dyspheroxamine? Dyspheroxamine has a short life and is safe for the infusion during ovulation induction therapy, and Dyspheroxamine should be avoided in the first trimester owing to lack of the safety data. It has been used safely after 20 weeks with the low doses. Okay, now another question is written here that or bisphosphonate safe in pregnancy. All the bisphosphonate are contraindicated in pregnancy and should ideally be discontinued 3 months prior to the conception in accordance with the product safety information sheet. Okay, now what is the importance of the genetic screening and what procedures are involved in the woman with the thalassemia? Okay, so that is written. If the partner is a carrier of the hemoglobinopathy, that may adversely interact with the woman genotypes, then genetic counseling should be offered. And in vitro fertilization, intracytoplasmic sperm injection with a peri-implantation genetic diagnosis should be considered in the presence of the hemoglobinopathy in both parents, so that the homozygous or compound heterozygous pregnancies can be avoided. Now, egg and sperm donors considering IVF should be screened for hemoglobinopathies. Now, preconception counseling for the woman with thalassemia include the partner screening and the genetic counseling. Okay, that is written in the table. Okay, we will discuss that later. Okay, as well as the method of the risk of the prenatal diagnosis and termination of pregnancy. In the high risk couples, a peri-implantation genetic diagnosis is an option, and if the partner is unavailable and an offer of the prenatal testing is appropriate due to the risk of the hemoglobinopathy, the potential egg and sperm donors are screened for hemoglobinopathies. Now, conditions requiring counseling where the woman is offered thalassemia. Okay, now carriers or suffer conditions in partners that includes the beta thalassemia, HBS, HBE, delta beta thalassemia, HB lipo, HB HB constant, HBC, other variant hemoglobin, and affected offspring include the risk of the serious hemoglobinopathy applies to all, and the risk of the mild to moderate disorder. Now, coming to the point 4.6, that what is the importance of immunization and antibiotic prophylaxis in the women who are at risk of the transfusion-related viral infections or who have the previous inactivity. Now, hepatitis B vaccine is recommended in the HBs negative women who are transfused or may be transfused. Hepatitis C status should be determined, and all women who have undergone splenectomy should take penicillin prophylaxis or equivalent, and all women who have undergone splenectomy should be vaccinated for the pneumococcus or Haemophilus influenza type B if this has not been done before. Women who are transfused regularly or intermediately are at risk of the transfusion-transmitted infection. It is therefore important to ascertain the infectivity and manage the common transfusion-related viral infections appropriately. The majority of the women with thalassemia major who have been immunized against hepatitis B, but some women with thalassemia intermediate may not. Hepatitis C is a common and often asymptomatic virus, so all women who are transfused require hepatitis C antibody testing. If the woman has a positive hepatitis C test, RNA titer should be determined with a referral to the hepatologist. And women who have undergone splenectomy are at risk of the infections from encapsulated bacteria such as Neisseria meningitis, Streptococcus pneumonia, and Haemophilus influenza type B. And UK guidance is that the daily penicillin injection is given to the high-risk splenectomized patients. Women who are allergic to penicillin should be recommended erythromycin. In addition, women should be given Haemophilus influenza type B and conjugated meningococcal C vaccine as a single dose if they have not received it as a part of the primary vaccination. The pneumococcal vaccine such as the Pneumovax 2 should be given every 5 years. Now, what vitamin supplements should be recommended? Folic acid 5 mg is recommended preconceptually to all the women to prevent the neural tube defect. And the women with thalassemia have a much higher demand for the folic acid, so high dose of the supplementation is needed. Folic acid 5 mg daily should be commenced 3 months prior to the conception. Antenatal care. Now, how is the specialist input delivered for the woman with thalassemia? Women with thalassemia should be reviewed monthly until 28 weeks of gestation and fortnightly thereafter. The multidisciplinary team should provide routine as well as the specialist antenatal care. Women with both thalassemia and diabetes should have monthly assessment of the serum fructosamine concentration and review in the specialist diabetic pregnancy clinic. All the women with thalassemia major should have undergone specialist cardiac assessment at 28 weeks of gestation and therefore as appropriate. Now, thyroid function should be monitored during pregnancy in hypothyroid pregnancy. The multidisciplinary team should include an obstetrician, a midwife with expertise of the high-risk antenatal care, and hematologist with an interest in thalassemia. A diabetologist and cardiologist may also provide additional specialist input. The pattern of the care should be individualized depending upon the degree of the end organ damage, and the woman with the cardiac or the diabetic or the cardiac functions may be reviewed more frequently. Cardiac assessment is important to determine the cardiac function and possible enable further iron chelation as well as planning of the labor. Now, the thyroid function should be determined periodically throughout the pregnancy, and if hypothyroid, the dose of the thyroid gene altered. What is the recommended schedule for ultrasound scanning during pregnancy? Women should be offered early scan at 7 to 9 weeks of gestation, in addition to the routine first trimester scan 11 to 14 weeks of gestation and detailed anomaly scan at 18 to 20 weeks of gestation. Women should be offered serial fetal biometry scan every 4 weeks from 24 weeks of gestation. Women with both thalassemia and diabetes have a higher risk of the early pregnancy loss. Fertility treatment with ovulation induction is often required to achieve the pregnancy, so as an early scan is indicated to determine the viability as well as the presence of the multiple pregnancy. Now, severe maternal anemia predisposed to fetal growth restriction in the woman with a thalassemia. Chronic anemia affects the placental transfers of the nutrients and therefore adversely affect the fetal growth. How should the transfusion regimen be managed during the pregnancy in the woman with thalassemia major? All the women with thalassemia major should be receiving blood transfusion on a regularly basis, aiming for the pre-transfusion hemoglobin of 100 grams per liter. Women with a thalassemia major will already be established on the transfusion regimen, which generally remains stable during pregnancy. In cases where the lower pre-transfusion thresholds have been used preconceptually, the aim is to achieve the pre-transfusion hemoglobin of 100 grams per liter. How should the transfusion regimen be managed during pregnancy in the woman with a thalassemia intermedia? If there is worsening maternal anemia or the evidence of the fetal growth restriction, regular transfusion should be considered. If the woman with thalassemia intermedia start transfusion, hemoglobin targets are managed as for thalassemia major. Women with a thalassemia intermedia who are asymptomatic with a normal fetal growth restriction and low hemoglobinopathy should have a formal plan outlined in the notes with regard to the blood transfusion in the late pregnancy. Okay, now the decision to initiate transfusion regimen is a clinical one based on the woman's symptoms and the fetal growth. If there is worsening maternal anemia or the evidence of the fetal growth restriction, regular transfusion should be started, aiming for maintenance of the pre-transfusion hemoglobin concentration above 100 grams per liter. Initially, 2 to 3 unit transfusion should be administered with an additional top-up transfusion if necessary, and the following week until the hemoglobin reached 120 grams per liter. The hemoglobin should be monitored after 2 to 3 weeks and 2 units transfusion administered if hemoglobin has fallen 100 grams per liter. Each woman's hemoglobin fall at the different rates after transfusion, so a close surveillance is required. Okay, of pre-transfusion is required. Now, generally, no non-transfused patients, if the hemoglobin is about 80 grams per liter at 36 weeks of gestation, transfusion can be provided prior to pregnancy, and postnatal transfusion can be provided as necessary. Okay, and if the hemoglobin is less than 80 grams per liter, then the aim for the top of transfusion of 2 units at 37 to 38 weeks of gestation. Now, coming to point 5.5, what antenatal prophylaxis is required? Okay, the first point is about the aspirin. Women with thalassemia who have undergone splenectomy or who have platelet count greater than 600 × 10⁻⁹ per liter should commence or continue taking low dose aspirin of 75 milligrams per liter. Okay, the second point is about low molecular weight heparin plus aspirin. Women with thalassemia who have undergone splenectomy and have platelet counts above 600 × 10⁻⁹ should be offered low dose heparin prophylaxis as well as low dose aspirin. Now, women with thalassemia who are not already using prophylactic low molecular weight heparin should be advised to use it during the antenatal hospital admission. Now, coming to the cause of the thrombotic tendency, women with thalassemia major or intermedia have a prothrombotic tendency due to the presence of the abnormal red cell fragments, especially if they have undergone splenectomy. And these red cell fragments combined with a high platelet count significantly increase the risk of the venous thromboembolism. And this risk is highest in splenectomized women with thalassemia intermedia who are not receiving transfusion, since the good transfusion regimen suppress the endogenous erythropoiesis. Now, coming to the point 5.6, what is the optimal antenatal management of the iron chelation therapy? Iron chelation therapy is a complex and should be tailored to the need of the individual woman. Management of the woman with myocardial iron. About this, it's written that the woman with myocardial iron loading should regularly should have regular cardiology review with a careful monitoring of the ejection fraction during pregnancy as a sign of the cardiac compromise are the primary indication for intervention with a chelation therapy. Now, the woman with the highest risk of the cardiac compensation should commence the low dose of the subcutaneous Dyspheroxamine, that is 20 milligram per kg per day on the minimum of 4 to 5 days a week. Okay, 20 milligram per kg per day on the minimum 4 to 5 days per week under a joint hematology and the cardiology guidance from 20 to 24 weeks of gestation. Okay, now the next one is about the cardiac MRI. Cardiac MRI is safe in pregnancy and should be undertaken in the pregnant woman, in the women who have not received the preconceptional assessment or where there is a concern about the cardiac function. As cardiac T2 values fall below 20 ms, there is increasing risk of the cardiac decompensation. Okay, and those women at the highest risk are those where the value is below 10 ms. Okay. Now coming to when the T2 is more than 20 ms, what we do? Women with a myocardial iron overloading and T2 of more than 20 ms and do not require Dyspheroxamine chelation during pregnancy unless there is hepatic iron overload. Okay, and another point is about women with T2 of less than 10 ms. Women with a Thalassemia Major and cardiac iron overloading with a T2 of less than 20 ms are 10 ms are at highest risk of the cardiac decompensation, which may present in an increasing breathlessness, paroxysmal nocturnal dyspnea, and orthopnea, syncope, palpitation, and peripheral edema presentation in the first trimester associated with adverse clinical outcome. Now, the next point is about the indication for cardiac assessment. If the woman describes the symptoms of palpitation, then the cardiac assessment is appropriate, and the falling ejection fraction or increasing ventricular volumes on echocardiography will suggest increasing risk of developing heart failure. If the woman complains of the palpitation, then a detailed history, ECG, and 24 or ECG monitor assessments are needed to confirm the pathological cause. In either circumstances, the Dyspheroxamine infusion may be indicated if there are concerns. Now coming to the another point, management of the woman with the iron, of the liver iron. Okay, management of the woman with the liver iron. Management with the severe hepatic iron loading should be carefully reviewed and consideration given to the low dose Dyspheroxamine iron chelation from 20 weeks. Now, iron load concentration. High concentration of the iron, liver iron of more than 15 gram per gram DW is measured by the MRI are associated with an increased risk of the myocardial iron. And all the women with Thalassemia Major, the therapeutic aim is to achieve the liver iron concentration below 15 milligram per gram DW to reduce the risk of the myocardial iron overload. Now coming to the intrapartum care. In the intrapartum care, what is the best intrapartum management for the woman with Thalassemia Major or Intermedia? The timing of the delivery should be in line with the national guideline. Senior midwifery, obstetric, anesthetic, and hematology staff should be informed as soon as the woman is admitted to the delivery suite. And in the presence of the red cell antibodies, the blood should be cross-matched for the delivery, since this may delay the availability of the blood, and otherwise the group and save will suffice. And in the woman with a Thalassemia Major, intravenous Dyspheroxamine 2 gram over 24 hours should be administered for duration of the labor. Now, continuous intrapartum electronic fetal monitoring should be instituted, and thalassemia in itself is not indication for cesarean section. Active management of third stage of labor is recommended to minimize the blood loss. Now, there is no specific evidence regarding the timing and the mode of the delivery. Okay, so that point is about the timing and mode of the delivery. When should be the timing and mode of the delivery? There is no specific evidence regarding the timing and the mode of the delivery for the woman with the thalassemia. The timing of the delivery should be based on the national guideline, depending on any issues identified in the pregnancy, that is diabetes or the fetal growth restriction. If otherwise uncomplicated, the pregnancy can be planned according to the local guideline. Now, medical complications. Okay, if there are medical complications such as cardiomyopathy, a detailed management plan formulated during the pregnancy should be in the woman's notes. Okay, And next point is about the blood transfusion. Depending on the timing of the last blood transfusion, the woman may well have a low hemoglobin. If the hemoglobin is less than 100 gram per liter, cross-match 2 units on admission to the labor ward. Okay, next point is about the peripartum chelation therapy. Women who are transfusion dependent or not on iron and not on iron chelation agents will have high risk of the serum concentration of the toxic iron species such as the non-transfusion bound iron, and these may cause the free radical damage and cardiac dysrhythmia when these women is subjected to the stress of the labor. The peripartum chelation therapy is therefore recommended. Now, continuous electronic fetal heart rate monitoring is recommended as a woman with thalassemia are considered to be at increased risk of the perioperative delivery due to possible fetal hypoxia. Now, women with thalassemia may have a low hemoglobin at the time of the delivery, and there is randomized controlled trial evidence that the active management of the labor reduces the blood loss. Now, coming to the postpartum care. Okay, what is written in the postpartum care? That is what we discuss now. What should be the optimum care for post-delivery? Women with thalassemia should be considered at the high risk for the venous thromboembolism. Breastfeeding is safe and should be encouraged. And there is a high risk of the venous thromboembolism due to presence of the abnormal red cells in the circulation. Women should receive the low molecular weight heparin prophylaxis in the hospital. In addition, the low molecular weight heparin should be administered for 7 days post-discharge following the vaginal delivery or for 6 weeks following the cesarean section. And women with a thalassemia major who plan to breastfeed should start the dyspheroxamine as soon as the initial 24-hour infusion of the intravenous dyspheroxamine finishes after delivery. Dyspheroxamine is secreted in the breast milk but not orally absorbed and therefore not harmful to the newborn. Okay, there is a minimum safety data on other iron chelation. Okay, if the woman decides not to breastfeed, intravenous or subcutaneous dyspheroxamine infusions are continued until discharge from the hospital or until resumption of her previous iron chelation regimens under hematology supervision, which so authorized sooner. Okay, now coming to the important tables in this guideline. First is about, that is appendix 1, booking appointment. Okay, first of all, we should give general information. Offer information, advice and support in relation to optimizing the general health, discuss information, education and advice about how thalassemia will affect pregnancy and primary care or the hospital appointment, and offer the partner testing if not already done, review partner if available, and discuss the prenatal diagnosis, amniocentesis or the cell-free DNA if appropriate, and take the clinical history to establish the extent of the thalassemia complications. Women with diabetes to be referred to the Joint Diabetes Pregnancy Clinic with the hematology input, and review medications, for example the iron chelation such as the deferriprone and deferriceros. And women should be taking 5 mg folic acid. Women should have the splenectomy. Women who had splenectomy should receive the antibody prophylaxis, and discuss vaccination with those women who have a splenectomy, and offer MRI heart and liver if these have not been performed before, and determine the presence of any red cell antibodies, and document the blood pressures, and send the midstream specimens of urine for culture. Confirm viability with the ultrasound. Now, in the schedule of antenatal appointment at 11 to 14 weeks, we will ask the midwife with a high risk of the obstetric complications experience. Okay, and review the partner results and discuss the prenatal diagnosis appropriate. Confirm all the actions from the first visits are complete. Continue folic acid 5 mg. Now, at 16 weeks, midwife and preconception review, hematology, obstetrician and diabetologist if diabetic, and 20 weeks midwife midwife and multidisciplinary review. And at 20 to 24 weeks, women should be assessed with the risk of the cardiac compensation. So start on the low dose subcutaneous dyspheroxamine 20 milligram per kg per day on a minimum 4 to 5 days a week, undergo a guidance of the hematologist with expertise in the iron chelation. Women with a T2 of more than 10 but less than 20 ms should be assessed for the risk and consideration to be given to the starting dyspheroxamine infusion if there are consent. Women with a T2 of more than 20 ms optimal preconception result should be given any dyspheroxamine chelation during the pregnancy unless there is severe hepatic iron overload. Now, at more than 20 weeks, midwife and multidisciplinary review, ultrasound for fetal biometry. At 28 weeks, midwife and multidisciplinary review and ultrasound for fetal biometry. And specialist cardiology review and formulation of the delivery plan based on the cardiac function. At 30 weeks, multidisciplinary routine assessment. At 32 weeks, midwives and multidisciplinary review and ultrasound for fetal biometry. At 34 weeks, midwife for routine assessment. And 36 weeks, midwife and multidisciplinary review, and a care plan regarding the delivery should be formulated by the team and documented in the notes. And ultrasound for fetal biometry, and offer information and advice about the timing, the mood and management of the birth, analgesia and anesthesia, and arrange anesthetic assessment if the cardiac dysfunction, care of the baby. 38 weeks, midwife and obstetric petition for the routine assessment and offer induction of the labor if the woman has diabetes. At 39 weeks, midwife for the routine assessment. At 40 weeks, obstetrician for the routine assessment. At 41 weeks, obstetrician for the routine assessment. And for non-diabetic women with a normal fetal growth and no complication, offer induction of the labor in accordance with the NICE guidelines.